Hey everyone, I'm going to go ahead and get us started. We're 1 minute past noon. So welcome to our annual Fall Implementation Science Seminar Series. My name is Dr. Alethea Terosiers, and I'll be hosting the Fall Seminar Series. I'm an associate professor in the Department of Psychiatry and Human Behavior at Brown University and a core faculty member of our Brown Research on Implementation and Dissemination to Guide Evidence Use, or BRIDGE program. This is now the 7th year of our implementation science programming, and we are thrilled to be able to bring these seminars to our Providence and Rhode Island community of implementation scientists, as well as those of you who are joining from other states or perhaps from around the world. We are grateful for the partnership of the Advanced Rhode Island Clinical and Translational Research, or Advance-CTR, for supporting the technology, logistics, and marketing of these seminars. And we also recognize our partnership with the Brown Alcohol Research Center on HIV for their support. Without further ado, I am very pleased to introduce our speaker today, Dr. Brittney Vanderwater. She is an assistant professor at the Connell School of Nursing at Boston College and a certified pediatric nurse practitioner and global health delivery researcher. She is also the associate director for pediatric nursing at SEED Global Health, where she supports nurse educators and partnerships with universities in Uganda, Malawi, Zambia, and Sierra Leone. Her research focuses on optimizing implementation of TB and TB-HIV interventions in low-resource settings and uptake of evidence-based strategies at large. She also focuses on building health professional capacity in sub-Saharan Africa. The title of her presentation today is Applying the Systems Analysis and Improve Approach, or SAIA, and Implementation Science Methods to Reduce Health Inequities and Barriers to Tuberculosis Care in South Africa. As a reminder, you can put your questions in the chat throughout the seminar, and we should have some time for questions and answers at the end. Thank you again so much, Dr. Vanderwater, and I will turn it over to you now.
Great. Thank you very much. Thank you for the invitation to present. It's really an honor to be the first speaker for this series. And thank you, Dr. Terosiers, for inviting me today. As she mentioned, I'll be talking about SAIA-TB, an intervention that I have running in South Africa right now. That'll be the majority of what we talk about. But I kind of want to start with a little bit of an outline, telling you a bit about TB and HIV in South Africa, which is a really high burden setting. Then we'll go through the comprehensive TB care cascade. We'll talk a little bit about partnerships and some of my previous work that really led up to the development of SAIA-TB. Then go through the use of routine data, different implementation science strategies, which I'll also describe a little bit earlier on, and some baseline results. Then I'll go through some next steps, and happy to take, hopefully we'll have like 15 minutes or so for questions and any comments you have. So hopefully a little bit of a discussion there. So first, to give you a little bit of a personal background, I've been a nurse practitioner for about 14 years, and then have had my PhD and been doing more research over the last 7 years or so. So I've been working on quite a few implementation science projects. I listed them out right here. Today, just because of time, I'm really only going to get into SAIA-TB. But I am working on quite a few other projects related to implementation science as well. I think it's helpful to think about why implementation science is useful. And to me, I think it's really pragmatic, especially in global settings and in any really low resource setting. So for example, the Me-Vacuna study that I'm a co-investigator on, this is taking place in a federally qualified health center in East Boston. And so it doesn't have to be global, but any kind of setting that needs support or is kind of low resourced, I think is where you really get the most kind of impressive outcomes. And I think implementation science helps close equity gaps, and it feels accessible and is visibly data-driven, which we'll look at today with the use of cascade analysis tools and continuous quality improvement forms. So this is a picture that I took in the Eastern Cape of South Africa, where across the country, TB has really been a leading infectious disease killer, both in South Africa and globally for decades. And this is despite available diagnostics, preventive treatment, and disease treatment. And so in South Africa, there's estimated 80% of the population actually has TB infection and is at risk of developing TB disease. A big driver of TB in South Africa is HIV. So there's about a 60% co-infection for HIV and TB in South Africa. And then the prevalence across the country, across ages and forms, is about 737 per 100,000 population. And this is from 2018 when South Africa did its first prevalence survey. So this is a picture, a graph that shows by province what the prevalence is, or sorry, the incidence of TB is across the country. And so at the bottom in yellow is the Eastern Cape. And that's the province that I do the majority of my research in, with the highest incidence of TB. This is a little harder to see, but kind of as a zoom in, showing the different districts across the country. And so again, at the very bottom in yellow, this happens to be the district that SAIA-TB is running in. And so this is the highest incidence of TB countrywide. And so I have done quite a bit of work. I'm not sure if you can see my mouse, but I have done quite a bit of work, and I'll tell you about it soon, in the OR Tambo district. And this has an incidence rate of 571 per 100,000 people, which is significantly less than in the Sarah Baartman district. But I think something important to remember is reporting issues. And so this is another area we'll talk about. And I think reporting issues, there's numerous reasons for these reporting issues, but OR Tambo is a much more rural district. They have some paper and electronic data capture. And so sometimes there's a lag in how data gets captured electronically. And so sometimes there becomes data that doesn't get captured in both systems. The Sarah Baartman district, yes, there's a good chance that their rate really is a lot higher, but also some of it may just be the implementation of good reporting systems that some other districts struggle with. And so thinking about why a comprehensive TB care cascade is important, it's because the care cascade evaluates TB outcomes across stages of patient engagement in a health system. And it really helps clinicians and researchers and really a whole community set targets and indicators to track. And oftentimes cascades are well understood because it follows this clinical pathway. Specifically in South Africa, with historically high rates of HIV, they have set national targets to reduce HIV through the implementation of multi-step strategies to diagnose, treat, and then virally suppress people living with HIV. And so these targets were called the 90-90-90 targets. And this was a really kind of simple yet really robust target that supported really incredible progress made in HIV, both in South Africa and across the world, that these indicators really achieved national uptake in reporting and utilization for direct clinical care. And so with this, TB experts have called for increasing the use of care cascades for TB programs, to also use comprehensive cascade indicators. So there are efficacious and low cost and safe TB screening, prevention, and treatment options. And there are evidence-based guidelines for TB management, both disseminated by WHO and by the South African National Department of Health. And so this cascade here depicts that the kind of the typical TB care cascade in South Africa, in potential gaps. So this was published by Naido and colleagues in South Africa quite a few years ago now. And so among individuals with TB, there are really still a lot of losses in this cascade. That this is showing us that there's an estimated 95% of individuals that access testing. Of those, 82% kind of move on to being diagnosed. 70% then are notified and treated. And eventually, unfortunately, only 53% have a treatment success. This here shows even less it is happening really in the TB preventive treatment cascade. This is really more inclusive of screening, testing for TB infection, referring if they're positive for disease, or making sure they get a medical evaluation, and then starting treatment for preventive therapy and completing that treatment therapy as well. And so this is kind of the definition of implementation science from the NIH. And I think this is important to help us close those cascade gaps that I just showed. That through implementation science and really studying the methods that promote the adoption and the integration of evidence-based practices and interventions and policies will help us get there. Or as a lot of people say, kind of just closing this no-do gap, that putting into practice what we know we should do, and studying why it does or doesn't work. And so I like to show these Proctor outcomes, and to think about kind of the questions that I often ask, which is about kind of the acceptability from patients and providers about interventions, or the adoption of guidelines, or the cost of not just TB drugs, but full TB programs. Thinking about the feasibility of introducing a new TB regimen. Is it too hard for patients to really understand the complexity of taking multiple medications at the same time? Are there too many barriers to implementing it, and barriers maybe in the documentation system? Is it too expensive, or are there too many competing priorities right now? That I was finishing my K-23 in the middle of COVID, years prior when the HIV epidemic was really hard. TB maybe lost some headway because HIV was really the priority at the time. Thinking about fidelity to what we set out to do in the protocol, that are we really doing in the program what we set out to do, or are we actually implementing a totally different project? So I'm definitely still interested in the effectiveness of programs, and how patients and clients kind of use these interventions, but more and more, I think my interests are lying kind of on the left side of this picture. And then this is a helpful slide, I think. You can see it from the bottom, adapted from Waltz and Powell and colleagues. This is from the University of Washington, who has a really strong implementation science program. But thinking through that implementation science is really fundamentally concerned with identifying effective strategies for implementing evidence-based interventions, or EBIs. And so really understanding the difference between a strategy and an evidence-based intervention. And so these strategies are really the actions taken to enhance the adoption or the implementation or sustainability. And then the EBIs are what are kind of known as the Ps, the programs, practices, principles, products, pills, or policies. And so thinking through SAIA, we are using some of these, which have kind of been domained here into different areas, to help us get to our final outcomes. So this is a slide to kind of differentiate these strategies versus EBIs, that you can get there sometimes through different ways. And so kind of our outcome of increasing detection, maybe it is both through the evidence-based intervention of active TB screening, right? We know this is evidence-based. We should be doing active TB screening for high-risk individuals, whether that's children under 5, people living with HIV, or household contacts. The strategy might be different. So in one community, we might use mobile chest X-ray vans, and the reason is to increase detection. Or we could use a different strategy, like community health workers doing home visits, again, with the same rationale of to increase detection. So I think writing these kind of sentences out in piecemeal like this is kind of helpful to help remind yourself or remind myself of what is my strategy and what is my program practice principle that I'm trying to implement in a different way. So I just want to take a minute to talk about some of the kind of partnership lessons learned that I've taken with me along the road. I spent a year teaching in Malawi, where I took this photo before really embarking on my research journey. And I think it's helpful, and as part of this kind of IS talk, to mention how important relationships and partnerships are, and that it takes time. That realizing, and again, I think this is probably more important in global settings or in low resource settings, or settings that maybe aren't where you come from. That often, I don't just walk into a hospital or a classroom and gain respect from colleagues or patients, but it's more from showing up day in and day out, sometimes virtually, like now on Zoom, that earns you the respect, and being part of this team, and letting people know that you're not just here for a week, or that you're just not showing them something novel, but that I'm like genuinely interested in working and partnering together. And that this has happened pretty organically throughout my career. So in the next couple slides, I'll talk about some of my pre-doctoral work and postdoctoral studies that has, again, kind of led up to where I am doing this SAIA-TB intervention. And so I did a lot of work in rural Eastern Cape at a hospital called Zitulele, and that partnership took a lot of time. So we started having email exchanges and Zoom calls in 2017 after they reached out because they were interested in working with my mentor in learning more about this idea of a zero TB initiative. And so I had already been doing work in South Africa, and they invited me to come visit when I was there in 2018. So, kind of a year went by. And so then I kept going back multiple times for either, weeks or months at a time in 2018 and 2019. And then during COVID, I ended up moving back to the US. And so we continued our weekly calls. But they knew I was really invested in them, in their hospital, in their community. And we had really gained each other's trust. So my K-23 was ending, and so we were submitting an R01 together. But at the same time, there was significant leadership change at this hospital. And there was a new hospital CEO that had led to making research collaborations a bit harder. And two of the main collaborators I was working with had moved on. But they were, really gracious and supportive, and said, now with this kind of change happening, maybe you should look for other partners. And we kind of brainstormed together that we already had other partners we had been doing this K award work with. And so they said, why don't you reach out to this organization called Equity? Everything we've done already has been really great. And so when this shift in proposal happened, we started having conversations with Equity, who was very interested in supporting this idea of SAIA. And we found out about the Sarah Baartman district, where I hadn't done work previously, but it was very serendipitous because it actually had higher rates of TB, which I thought, that's a good rationale to move there. And two, it actually was inclusive of where my husband's town is. And so it made, it a lot easier to be closer to family. And we had already developed a pretty positive relationship with this new partner. So again, just to kind of conclude this slide about partnerships, I think being flexible and agile is important, but being mindful that in low resource settings, research is really complex. And I think kind of managing your expectations and others' expectations is really important, and realizing the kind of dynamic possibilities of partnerships is really kind of a wonderful and beautiful thing that can happen. So to kind of get back to TB, the first study I conducted was, and I'm going to run through these somewhat quickly. The first study I conducted was a systematic review of barriers to initiating TB treatment in mostly adolescents and children in sub-Saharan Africa to really understand the problem. And we found that removing barriers to initiation happened both at the patient and the system level. In the second study, we really looked at time to drug-resistant TB treatment. And this is in about 500 patients, both in the Eastern Cape and KwaZulu-Natal. And we found that 84% of patients had delays in treatment initiation beyond national guidelines, which doesn't sound great. However, the national guideline recommends starting treatment in 5 days or less since diagnosis. The median time that we had found was 11 days. So it wasn't too bad. And it was actually within the 2 weeks, which is recommended by the WHO. So although they, didn't meet their own national guidelines, they did meet the WHO requirements. However, again, this is really critical because rapid treatment is important, one, for patient outcomes and the spread of TB. And then third, we looked at prescribing patterns of healthcare providers. And we found good news, 88%. So most patients received the correct 5 medications for drug-resistant TB. However, only 30% of patients, so less than a third, received full guideline recommended regimens. And the issue really came in around dosing guidelines. And so most patients were actually underdosed, which in TB can be a really crucial, important piece of the picture for developing more drug resistance. And so I think with these 3 examples, you can see that my questions, and I was really interested in understanding kind of these system level factors, that it really wasn't just patient adherence to medications in that, or starting treatment in that first article, but it was a lot of system infrastructure or medication stockouts or lack of access to clinics that were too far from patients, that was really hard. And that in this long wait in the second paper, some patients ended up dying from disease because they waited too long. And so again, this is like a systems issue bottleneck. And same with these guideline-based care, that issues around dosing. And so ensuring providers have access to guidelines, charts to document, and prescribing correctly is really paramount. These are all very implementation science-based questions to look at. So as I've progressed in my career, like I mentioned, I collaborated a lot with 2 drug-resistant TB hospitals that I had already been working with, as well as Citralele to do more drug-sensitive TB work. So we started looking more at full cascades. And so looking at a prevention care cascade for drug-resistant TB, as well as a prevention cascade for drug-sensitive cascade. And then finally, in this third paper, we evaluated the implementation of a household TB preventive therapy program and some of the surrounding clinics, and looked at the barriers and facilitators to implementing it among the healthcare workers who were involved with it. And then this paper is still under review, or I guess it was just accepted, but we did present it at a poster at the North American Regional TB Conference a few months ago, looking at the actual effectiveness of the program. And so this is really all, as I mentioned, kind of led to SAIA-TB, which is this using the systems analysis and improvement approach for TB. And so SAIA, which I'll talk about in 2 slides from now, is kind of this cyclical systems engineering strategy that one of my mentors at UW, Sarah Gimbel, developed with colleagues there to help clinics at kind of a facility level improve any kind of condition. It's been used in mental health. It's been used for diabetes, hypertension, HIV, cervical cancer screening, family planning, quite a few different disease areas. And we have adapted it to TB. And so these are the main aims of the study. And we really want to assess, eventually the effectiveness, but really looking at the drivers of success and understanding the acceptability and preferences of the different components of SAIA-TB, eventually and ultimately to have an impact on community TB transmission. So SAIA-TB is taking place in 16 clinics across 4 local municipalities. You can see in the map here, Kokama, Kuka, Sundays River Valley, and Ndlambe. And so I've been working in the Eastern Cape for about 10 years. I spent about half of 3 or 4 years living in the Sarah Baartman district. And so the partner organization working with Equity, their main office is in Pretoria, but then we have a small office in Koberha, which is kind of in between Sundays River Valley and Kuka, right on the coastline. And so Equity has, deep roots with the Sarah Baartman district and has been operating there as well as throughout other parts of the Eastern Cape for quite a few years. And it's a South African owned and operated NGO. It's just a picture of one of the 16 clinics in Port Alfred. And just an example of, it's a pretty heterogeneous area. Some parts are quite rural, others are kind of a mix of rural and urban, a lot of farmland, a lot of kind of fishing communities. So a nice mix of population and setting. So the systems analysis improvement approach, it is an evidence-based implementation strategy. So again, thinking back to that earlier slide, it is both evidence-based. There's enough evidence around SAIA to say this is a strategy that has worked well before. And this combines systems engineering tools into really a 5-step clinic or facility level package. And so this is to give clinic staff and clinic managers really a system-wide view of their TB cascade performance, helps them identify priority areas where they can improve, and help discern modifiable opportunities for improvement, and to help test workflow modifications. And so this cycle is really iterative, allowing healthcare teams continuous use of this SAIA package to further improve care and respond to potentially new bottlenecks that arise throughout kind of care systems. So we will use SAIA monthly with the clinic teams and the Sarah Baartman district management and the clinic staff during the intervention. And so our hope is that this will continue, these monthly SAIA meetings, without our study staff during the maintenance phase and into the future. So thinking about this getting adopted into the general workflow of the clinics that we work in. So our project team is made up of quite a few different people. This is a list of co-investigators, the project manager, Betty, who is, I'm really sad I don't have a picture of Betty here. I think I do later in the slides. Betty is full-time and really leading the charge with our 4 research assistants on kind of day-to-day management of the study. So this is our study design. So it is a stepped wedged crossover study. So currently here you can see kind of end of 2024, all clinics, all clusters are still in the baseline data collection phase. In January, cluster 1 will start the intervention. And so in August at one of our stakeholder meetings, we actually did live randomization where a group of people were all together in the same room and pulled from a hat which cluster is going first. So it's going to be Kokama, who starts first, then Sundays River Valley, Kuka third, and Ndlambe will be our last cluster. And so each cluster has 4 clinics Each of the clinics and each, like I've just said, each cluster has 4 clinics. Each clinic has roughly a catchment area of 5,000 to 10,000 people. So we think over the 18-month intensive phase of the study, we should include nearly 20,000 patients to be screened for TB. So it sounds like a lot, but that's about 1,200 from each clinic, or about 70 patients per clinic per month during the intensive phase, which, breaking it down piece by piece, is really only 3 to 5 patients being screened per day per clinic, which is feasible. It's happening already during the baseline that we can tell. So these are the phases, and this is kind of what happens in each phase. And I'll go through in the next slides what each kind of piece of SAIA entails. So at baseline, we have already done an orientation from the study team with the district health authorities. We had a couple different meetings with district and provincial managers. We've also met with the national TB director, and we have initiated data collection at all 16 clinics. We are also doing reporting of our TB cascade analysis tool, or our TCAT variables. And this right now is only happening with our study personnel, so our 4 research assistants. Once the intensive intervention starts in January, so we have scheduled in November our training with the first cluster. So we'll do a training at each of the 4 clinics. We'll teach them the principles of SAIA and discuss pretty in depth what process mapping is. We'll practice populating and interpreting the TCAT. We'll develop process maps, and then we'll also look at how we define micro interventions and develop indicators on how we will monitor these micro interventions and decide on modifications to kind of adopt, adapt, or abandon the interventions that they do on a monthly basis. During this time, clinics receive bi-weekly supervision, and then over time, that will kind of reduce to just monthly visits during the entire phase, where they'll have these like SAIA monthly meetings. And eventually the green area, the maintenance phase, they'll continue having these monthly SAIA meetings and going through these cycles, but we will not have our study personnel to kind of lead these meetings. Those meetings will hopefully be led by staff and kind of champions that have kind of identified themselves in each of the clinics. Our study personnel will still be populating a TCAT, but kind of in the background. So this is an example of the data collection we have planned, of kind of continuous cascade analysis tool data entry. You can see in month 18, our continuous quality improvement data will start to be entered on a monthly basis, and as well as our kind of study logs and notes. We'll have all of those being entered continuously once the intervention starts. This is an example of the cascade analysis tool, and this is just a little blown up so you can see it. So this helps us understand the targeted TB cascade performance areas and identify priority areas for improvement. And so this TCAT uses routine data to provide a rapid systems level view of drop-offs along the cascade, where we can help prioritize subpopulations, such as maybe children under 5 or people living with HIV. We might want to prioritize pregnant women. And so we can do that because we're collecting a little bit more data than just these TCATs in our REDCap database. But these TCATs, which is just in Excel, has an optimization function which allows the user, which right now is study staff, but eventually will be clinic staff, helps them rapidly assess how many additional patients will be served if only one step is fully optimized while other steps stay the same. So this is an example of, this is sort of the screening section of the tool. This is the disease section of the tool. And then finally, this is the preventive treatment steps of the tool. And so just as a reminder, as I kind of mentioned before, these TCATs help frontline staff and clinic managers prioritize where to intervene by providing a general view of kind of the greatest potential for flow improvements across the entire cascade. This is just kind of another visualization to kind of look at the cascade. Step 2, and this is what we'll do at the trainings with each of the facilities, is process mapping. And these will enable us to gain consensus on bottlenecks to address and identify potential micro interventions, which the clinics will decide which ones to choose during their monthly SAIA meetings. And so in that table, you can see kind of potential micro interventions. So if you've never seen process mapping, these are all taken from SAIA training materials from a previous training that, again, my mentor, Sarah Gimbel, has previously done with the University of Washington. This was in maternal to child transmission of HIV. So first, you have a hand-drawn map. And so this is like kind of messy. Then you kind of move to a computer-generated map, this is kind of your simple map, although not overly simple. And then here it is a little bit more complex. You can see here are potential areas to pull out. And so what you do at the end of process mapping is decide on what areas unambiguously add value to patients, what steps add no value to patients, but are actually unavoidable. And 3, which add no value to patients, but are avoidable. And so these circled areas were identified as adding no value to patient and were also deemed avoidable. And so these are kind of your bottlenecks where you can say, we can actually do something about this, and empowered the clinic staff to say, maybe we could change this. And so after identifying that in a process map, then you can start using on a monthly basis these continuous quality improvement forms. And it's really, this is more like action planning. The first half, A through J, are completed at planning, and then K through N are completed after the micro intervention is completed. Again, kind of on a monthly basis. And I love column N. Do you plan to adopt, adapt, or abandon this micro intervention? So again, going back to what I originally said of, it's just pragmatic and very visual. People, you can kind of see month by month which line you filled out and the progress you've made. So this is just a simple way, again, to kind of look at our TCAT, which is really what make up our primary and secondary outcomes. So coming full circle, really, the SAIA strategy, I think it can be useful in TB care, because again, it's an evidence-based implementation strategy, and because TB is already using routinely collected data, it's something that clinic staff is already trying to fix, and a lot of these modifiable bottlenecks are within frontline staff's purview to make change with. It's kind of within the provider control of potentially better documentation, ordering pharmacy to prevent stockouts, or adding indicators that might be useful in the full cascade. So systems engineering, as kind of a wrap up, can be used in global health contexts to optimize health services. And these are really the three things: to diagnose problems and identify needs, to evaluate decision options through modeling or optimization, and then translating these decisions into practical recommendations or actions. And to give a quick update on where we are, we've recently completed facility readiness assessments in all 16 clinics. So we did one set of readiness assessments before even starting our baseline. And that's because we were a little concerned about even just going into clinics and having one research assistant weekly helping with reporting. That might change how documentation is done. And so even though we haven't started the actual intervention, even just our presence there may have changed things. So we've done a baseline facility readiness assessment, and now we've actually repeated it before we start the intervention. These are some of the things we've found. And then we've also spent a lot of time tailoring the TCAT, working with local staff to understand where these source documents originate from. We've held 2 quarterly stakeholder meetings with study team, district, as I mentioned, provincial health officials. And then we have weekly data reviews and validation meetings. We've also published a protocol. So if you want to review kind of anything I've gone over, you can find our implementation science communications protocol paper. And then we've presented at the South African TB conference. And then we have our stakeholder launch and trainings coming up in November. So with that, I'm happy to take questions. There might be some in the chat already.
Thanks so much, Dr. Vanderwater. I will monitor the chat as questions come in, but I can kick us off. That was a really impressive presentation on your work, and I loved learning more about the systems engineering approach and your work to apply those methods of SAIA as a strategy in South Africa. I was wondering if you could share a little bit more about how you evaluated facility readiness, what kind of metrics went into that, and just to describe that process a little bit more.
Sure. Yeah, so we actually, there's a WHO tool called the SARA. SARA. I don't know what it actually stands for, but it's a tool that looks at kind of facility resources. And so we looked at that. It's a very lengthy tool. And so Equity had also recently done facility assessments in in Amatole district, a different district in the Eastern Cape specific to TB. And so we kind of took both the SAIA tool as well as this already created TB specific tool and put them together and used a little bit of each. Some of the things we considered were pretty simple metrics of how many staff do you have, how many nurses, how many monitoring and evaluation like data captures do you have? Do you have a pharmacist, or is it a pharmacy tech? Asking if they have, working computers and how often they have pharmacy stock out. So kind of general facility questions. And then also asking if they have looking at their TB indicators. So getting a sense of what their kind of monthly and quarterly reporting is. I don't know if that's kind of what you were looking for.
Yeah, that's super helpful. Thanks for explaining it a bit more. And I think it sort of highlights how much really goes into the pre-implementation phases and how important that work is prior to getting going. We have a couple questions down the chat. One question is about who the folks will be at the training sites in the SAIA approach. Like, what is their background, their level of training, if you could share a bit more about that.
Sure. Yeah, great question. So we have talked a lot about actually where to hold the trainings, that some other groups who have successfully implemented SAIA in Kenya, in Mozambique, in Washington State, if we wanted to bring together all 4 of these facilities, or if we wanted to actually go into each of their facilities. And so we've decided for our purposes, because it's not really that many facilities, it's probably better to go to them rather than have them kind of come to us. And so we're asking the whole clinic staff to come, as well as really anyone working at the clinic. So inclusive of janitorial staff, if they're there during the day, and the admin clerk who checks in patients, because a lot of times when you think about task shifting, so in one of the sites, it is a lay person with very little training who is running the pharmacy right now, because their pharmacy tech had to leave. And so thinking about like how you fill gaps in personnel, we want to train really everyone. And thinking again, is it necessary to have the nurse do a symptom screen for TB, or is that something that could be done immediately when someone gets registered at the clinic, and that could be the admin clerk? So we're really inviting everyone, and you'd be surprised who the champions end up being sometimes, I think.
Great, thank you. We have a comment and a question. First, I love your emphasis on partnerships and the importance of putting work into them. And then the question is, I agree. I'm really glad you added that to the presentation, because it is so important. How did you work together with the partners to select and carry out the implementation strategies, which I guess was mainly SAIA, unless there are some other ones that you thought were important to mention here?
Yeah, great. Thank you for that question. So we did come up with a list of criteria, just that we knew, a clinic with 1 nurse would probably be too small, or a clinic that was too rural, that just didn't have a high enough volume of patients. So we do have some criteria of what we needed for sample size, and for SAIA to work, right? It's a group effort. And so you can't really brainstorm if it's a 2-person run clinic and you're just trying to get clinical care done. So we had a minimum number of nursing staff. I think it was at least 2, so not overly stringent, and a minimum, I forget how many, it's in the protocol paper, but a minimum of, 4,000 patient visits, I don't know, per quarter or something. So we needed a certain number of volume. And then other than that, we really worked closely with the district manager, Dr. M. Zeleny. She's an obstetrician, but really works in a management position to see which sub-districts or local municipalities she thought would be most fitting. And that's how we came up with the 4. And then within those 4 chose clinics that met the criteria. And we also said, again, logistical reasons, we needed it within like 2 hours of Queberha, where our office was, so that, staff could move between. I think I answered all of those questions.
I think you did. Thank you. And then maybe one more quick question, because I know we're about running out of time here. There was a question about whether these were government-run facilities, and if so, how did you go about obtaining any approvals that were needed?
Yes. Yep, they're all government, full government clinics. And South Africa, you need both IRB approval by a local institution. So we got it through Walters. Sorry, I've gotten it from Walter Sisulu before, a university in the Eastern Cape. We got it through the SAMREC, the South African Medical Research Council. One of our co-investigators, Marion Loveday, works there. And so we got it through her affiliation in that institution. And then the Eastern Cape Department of Health also gives out a provincial letter of approval. And then that's all you need. So you need both an IRB and then a letter from the province you're working in.
Great. Thank you for that. Well, I think on that note, we will give everybody a minute back into their day. And thank you so much again. As a reminder, the recording will be available. The link is in the chat about a week after the seminar. And apologies for any questions that were put in the chat that we didn't get time to ask today. But thank you everyone on Zoom who attended the seminar series today. And as a reminder, next Tuesday, October 15th at 12 p.m., we will have Dr. Rosemary Mesa presenting on causal pathway diagrams, understanding how and under what circumstances strategies work. So we hope you can all join us again next week. And thanks again. Take care, everyone.